Hello, my name is Anna Rutherford. I'm the Clinical Director of Hepatology at Brigham and Women's Hospital. I'm going to be speaking about acute liver failure. I have no disclosures relevant to this presentation. Today I'm going to be talking about the definition of acute liver failure, cover its epidemiology, pathogenesis, some specific therapies, management of complications of acute liver failure, assessment of prognosis, and outcomes. The most reliable defining markers of acute liver failure are an INR of greater than or equal to 1.5, altered mentation or encephalopathy, a length of illness less than 26 weeks, and no pre-existing liver disease. This is a fairly rare entity in the United States. About 2,000 cases occur a year. No one medical center can study the condition. It occurs from a variety of different etiologies, which we'll review. There's no viable treatment for all patients. And prior to liver transplantation, the morbidity and mortality of acute liver failure was 94%. Patients with acute liver failure that meet the definition previously described can be listed for liver transplant, status 1 for 7 days. This means they'll be the first person to obtain an organ in their region in their blood type. Prior to the 1980s, hepatitis B comprised over 40% of the cases of acute liver failure. This was before we had oral antiviral therapy. The Acute Liver Failure Study Group, which was set up in 1998, made up of a number of academic centers in the United States, started compiling data on all patients who presented to their centers with acute liver failure. What they found is that the etiology of acute liver failure in the United States is 46% acetaminophen, 11% other drugs. There's a component of about 14% that are indeterminate. Viral hepatitis B is about 7%. Autoimmune hepatitis is about 5%. Wilson disease is about 2%, and hepatitis A is about 3%. If you compare this with other parts of the world, you can see that the etiologies of acute liver failure vary dramatically geographically. In Southeast Asia, hepatitis E and hepatitis B are much more common than medications. And in the United Kingdom, acetaminophen is much more common than a cause of acute liver failure in the United States. Different etiologies have different presentations. They occur in different patient populations. And some have a very dramatic presentation, such as an acetaminophen overdose, where a patient has a limited time where they go from developing both jaundice and a coma. They have very high transaminases and fairly low bilirubins. What probably distinguishes different etiologies of acute liver failure the most is their transplant-free survival. As you can see, patients who have acute liver failure from acetaminophen or hepatitis A, their likelihood of surviving without a liver transplant is over 50%, whereas patients who have acute liver failure from another drug, an indeterminate etiology, or hepatitis B, or all others, including autoimmune liver disease and Wilson disease, these patients have a fairly dismal transplant-free survival. So let's start by talking about acetaminophen. This is a $1 billion problem in the United States. It's an over-the-counter medication, and there are over 300 types of acetaminophen. It's a unique dose-related toxicity and is responsible for over 100,000 calls to poison control annually, 50,000 ER visits per year, and 10,000 hospitalizations per year, leading to up to 500 deaths per year. Hydrocodone acetaminophen is the number one generic prescription drug. There are over 100 million prescriptions of this per year. Its different names include Lorcet, Lortab, Maxidone, Vicodin, and Zydone. Since 1998, where we saw that the United Kingdom, who has even a greater problem with acute liver failure from acetaminophen, they have been limiting the package size of acetaminophen to 16 to 24 tablets and employed blister packs. And they found that by limiting the amount that you can buy of acetaminophen, it's decreased complications by up to 33%, including hospital admissions, need for liver transplant, and death. The FDA has had multiple meetings with an advisory committee about this issue, and some of their recommendations are starting to be administered. This includes prescription combination products that contain acetaminophen and a narcotic, limiting the amount of acetaminophen able to be paired with a narcotic to no more than 325 milligrams in each tablet or capsule. The FDA is also requiring manufacturers to update labels of all prescription combination acetaminophen products to warn of the potential risk for severe liver injury. How is acetaminophen metabolized? It's a dose-related toxin. A higher dose means more is processed by the cytochrome P452E1 to a highly reactive intermediate known as N-para-aminoquinamine, or NAPQI. A normal detoxifying process is glutathione in the body, which will allow this to be excreted in a non-toxic mercaptocuric acid. In patients who are glutathione deficient, or if the dose of acetaminophen they take exceeds this pathway, NAPQI will cause a lot of hepatocyte damage, cysteine adducts, covalent binding to cell proteins, which causes overall liver damage. The antidote to acetaminophen toxicity and acetylcysteine is giving high doses of glutathione in hopes of channeling the majority of this NAPQI into non-toxic mercaptopuric acid. There are two types of acetaminophen overdose that cause acute liver failure. There's the intentional overdose, where a patient takes at one time point takes a large amount of acetaminophen in an attempt to kill themselves. The alternative is an unintentional overdose, which is more commonly someone taking acetaminophen over several days, specifically for pain relief without suicidal intent. Often the acetaminophen in this situation is coupled with narcotics, and patients may not even be aware that they're taking a medication that includes acetaminophen. And they both come to presentation with acute liver failure. Interestingly, both groups' age is fairly similar. The majority of patients who have acetaminophen-related acute liver failure are female. The total dose in someone who's taking an intentional overdose as opposed to an unintentional overdose is slightly higher. These patients are more likely to have depression, equally likely to be on an antidepressant. As you can see in the unintentional overdose, these patients are more likely to be using multiple preparations that include acetaminophen and narcotic compounds as well. The interesting thing, and these are about 50-50 in terms of presentations we see for acute liver failure related to acetaminophen, they both do equally well. Between 64 and 66% of patients will survive acute liver failure from acetaminophen without a liver transplant, and about 27% will die without a liver transplant in each group. If you look at other types of drugs that cause acute liver failure, this comprises about 11% of acute liver failure cases overall. Again, this is more likely to occur in women. But unlike acetaminophen, outcome from other drug-related acute liver failure, these patients do not do well. 30% will survive without a transplant. Most cases of acute liver failure related to drug-induced liver injury occur within the first 6 months after drug initiation. If you look at the breakdown, about 46% of these are antimicrobials. Nearly a quarter of these are complementary alternative medications, herbal medications, and another quarter of these are antimetabolites, NSAIDs, or biologic agents. The NIH website, Liver Talks, has a specific list for drugs that cause acute liver failure. As you can see here, some of the common medications, but at least a quarter of these that are on the list are complementary alternative medications. Viral hepatitis causing acute liver failure is a smaller group. Most commonly, it's hepatitis B, about 7%. Hepatitis A is about 3%. And there are few, if any, cases of hepatitis C causing acute liver failure. Despite the fact that we recommend vaccination for patients with chronic liver disease against hepatitis A, there is no clear increased risk of hepatitis A-related acute liver failure in patients who have chronic hepatitis C. Hepatitis A occurs in the United States most commonly related to food contamination. Hepatitis B is the most common viral etiology of acute liver failure in the U.S. And often can be related to chemotherapy reactivation. Hepatitis E, which is endemic in Russia, Pakistan, India, and Mexico, is more recently occurring more in patients in the United States who have not been traveling, and so should be tested or checked when patients present with acute liver failure. Other viruses that have been known to cause acute liver failure include parvovirus B19, hepatitis D, Sen virus, dengue, HSV, and VZV. Wilson disease is about another cause of acute liver failure. About 5% of patients who present with Wilson disease will present with acute liver failure. This is nearly always fatal without liver transplant. Clinical characteristics of the acute liver failure related to Wilson disease include a high bilirubin, a low alkaline phosphatase, an alkaline phosphatase to bilirubin ratio of less than 2, hemolytic anemia, acute renal failure, Kaiser-Fleischer rings on slit lamp eye exam about 50% of the time. And interestingly, these patients, although they present with acute liver failure, are often cirrhotic at explant. In 2008, a group published a way to rapidly diagnose acute liver failure related to Wilson disease. They found that if you had a ceruloplasmin less than 20, an alkaline phosphatase to bilirubin ratio less than 4, and an AST to ALT ratio of greater than 2.2, the sensitivity and specificity for diagnosing acute liver failure from Wilson disease was 100%. Other etiologies of acute liver failure include Amanita phalloides mushroom poisoning, some organic solvents, herbal supplements, acute fatty liver of pregnancy and Ray's syndrome, shock liver, Budd-Chiari syndrome, veno-occlusive disease, most commonly a complication after bone marrow transplant, heat stroke, hepatic artery thrombosis, autoimmune hepatitis, tumor infiltration, and primary graft non-function. Hepatic artery thrombosis and primary graft non-function are most commonly complications that occur right after liver transplantation. Very generally, the pathogenesis of acute liver failure involves massive hepatocyte necrosis and apoptosis, release of cellular contents, development of components of hepatic failure, a massive cytokine storm, and hopefully some hepatocyte generation. Here is a diagram that shows that acute liver failure, though starting in the liver, really affects almost all organs, the brain with hepatic encephalopathy, intracranial hypertension, and the risk of cerebral edema. Kidneys, patients often have kidney dysfunction or failure. Patients develop portal hypertension, frequent bone marrow suppression, and acute lung injury. In the liver, the components of hepatic failure related to decreased metabolic function of the liver include impaired gluconeogenesis causing hypoglycemia, impaired lactate clearance causing lactic acidosis, impaired ammonia clearance causing hyperammonemia, and impaired synthetic capacity of the liver causing coagulopathy. There are not that many specific therapies for acute liver failure that work. Three that there are data-driven recommendations for include N-acetylcysteine for both acetaminophen and non-acetaminophen acute liver failure, prompt delivery in pregnancy-related acute liver failure, which is usually HELP syndrome or acute fatty liver of pregnancy, and liver transplantation. Other things that are used with perhaps less data supporting them are activated charcoal, high-dose IV penicillin or sibulinin, also known as milk thistle, for Amanita mushroom poisoning, corticosteroids for autoimmune hepatitis related acute liver failure, copper chelation, plasmapheresis, and antioxidant therapy for Wilson disease-related acute liver failure, lamivudine or entecavir for acute liver failure related to hepatitis B, acyclovir for acute liver failure related to hepatitis HSV, TIPS or surgical decompression for acute Budd-Chiari, and hemodynamic support for ischemic liver injury. N-acetylcysteine for acetaminophen-related acute liver failure works better if it is given within the first 48 hours. As shown on the diagram, this is to replete glutathione stores in a patient, so that if they have taken an overwhelming amount of acetaminophen, it will allow more to be excreted as a non-toxic mercaptopuric acid. And acetylcysteine should not be withheld even if acetaminophen ingestions are over 48 hours prior. Oral is first-line therapy for patients presenting with acetaminophen overdose, or if they have mild encephalopathy. If patients are very encephalopathic or nauseated or hypotensive, they should be given IV N-acetylcysteine. And there are no clear guidelines about how long one should receive N-acetylcysteine, but usually it's until there's firm evidence of improved hepatic function, improved hepatic encephalopathy, improving INR, and declining transaminases. In a large study done in 2009 looking at N-acetylcysteine in patients who had non-acetaminophen acute liver failure, there was no difference in overall survival when all comers with acute liver failure were given N-acetylcysteine versus placebo. However, there was one group, patients who presented in early coma stage, grade 1 and 2, had improved transplant-free survival when they received N-acetylcysteine. Each year, between 3 and 6% of patients listed for liver transplant are listed because of acute liver failure. Overall, about 45% of patients with acute liver failure are listed for liver transplant, and about 25% receive a transplant. As mentioned, patients are able to be listed status 1 for 7 days. Status 1 implies that they are unlikely to live longer than 7 days due to the severity of their illness. And it allows them to surpass everybody on the liver transplant list. So status 1 surpasses the highest MELD score on the list. In patients who are transplanted for acute liver failure, they have a 90% 1-month survival and a 70% survival at 1 year. Most diseases do not recur. There have been reports of repeated overdoses with acetaminophen-related acute liver failure, and also autoimmune hepatitis has been known to recur in a fulminant way post-liver transplant. There are a few nonspecific therapies for acute liver failure. One is therapeutic hypothermia. These are patients with grade 3 or 4 encephalopathy who receive therapeutic hyperthermia and are cooled to 32 to 35 degrees. They compared 97 ALF patients and over 1,000 controls. They measured intracranial pressure in nearly 40% of patients with therapeutic hyperthermia and 22% of the controls. Hypothermia was not associated with increased bleeding or infections. It overall did not affect 21-day overall or transplant-free survival, except in a group of patients who were less than 25 years old and had acute liver failure from acetaminophen. There was an improvement in survival in the group that had therapeutic hypothermia. Other non-specific therapies for acute liver failure include hepatic assist devices. These can be broadly divided into non-cell-based detoxification systems, single-pass albumin, plasma exchange, Some in this situation are Prometheus or Mars, or a cell-based system to provide metabolic support and detoxification. There are 5 cell-based systems that have been assessed clinically, listed below. These all differ in cell source, mass, and whether they use plasma versus whole blood. The summary statement of hepatic cyst devices is they all appear to be safe and have some biologic effect, yet that none have received FDA approval in the United States. So moving on to management of acute liver failure complications. It's important to keep in mind that the leading causes of death in patients with acute liver failure are cerebral edema and sepsis. I'm now going to talk a little bit about management of hepatic encephalopathy, infection prophylaxis, use of sedation and analgesia in these sick patients, correction of a coagulopathy, nutrition, circulatory dysfunction, cerebral edema, and assessment of prognosis and need for liver transplant. I'll start by reviewing the grading of hepatic encephalopathy. Grade 1 encephalopathy is mild confusion associated with incoordination or a slight tremor. Grade 4 is a coma, where you can also see decerebrate posturing and loss of response to stimuli. Early encephalopathy, grade 1 or 2, is often considered versus someone presenting with acute liver failure having advanced encephalopathy, grade 3, or in a coma, which portends a poorer prognosis. So in managing hepatic encephalopathy in these patients, we do have medications, non-absorbable antibiotics. There's less data on whether to use these in patients with acute liver failure and hepatic encephalopathy. If we do, titrating lactulose to avoid intravascular volume depletion or hypernatremia. Avoiding things like neomycin because of a risk of nephrotoxicity. And really, if patient presents with advanced encephalopathy, grade 3 or grade 4, these patients should be intubated to avoid risk of aspiration. Infection prophylaxis. The most common site of infection in patients with acute liver failure is the lung, followed by the urinary tract and the blood. Up to a third of patients with acute liver failure will develop fungal infections. They're considered profoundly immunocompromised when they're this sick. There's insufficient data to support routine antibiotic prophylaxis in all acute liver failure patients, particularly if they present with early encephalopathy, grade 1 or 2. Daily surveillance blood cultures and a chest X-ray is recommended because acute liver failure patients, because they're immunocompromised, may not exhibit standard infectious signs. There is data to recommend empiric antibiotics in these patients if they have a surveillance culture with a significant isolate, if they progress to more advanced hepatic encephalopathy, stage 3 or 4, if they develop hypotension or the presence of SIRS. Considering sedation and analgesia, most of these patients are in an intensive care unit, and many are intubated. Psychomotor agitation and pain can increase intracranial pressure, which is something we like to avoid in these patients. Propofol and benzodiazepines, which are the most popular sedatives in the ICU, may exacerbate encephalopathy. Recovery from propofol is short and may allow transplant teams to assess a patient's neurologic examination more quickly. Propofol is also known to decrease cerebral blood flow, which can lower intracranial pressure, which is a good thing. Morphine and Demerol are not recommended as analgesia due to active metabolites accumulating in a setting of severe hepatic dysfunction. By definition, patients with acute liver failure have a coagulopathy. Interestingly, despite this, spontaneous clinically significant bleeding is uncommon in acute liver failure patients. All patients should receive vitamin K for 3 days just to see if there's a dietary component to their elevated INR. But there's no data to support prophylactic FFP. In fact, it's sometimes nice to be able to follow the INR to see if the liver is getting sicker. If patients have hypofibrinogenemia, less than 100, cryoprecipitate is recommended. If they are having a high-risk bleeding procedure, such as a liver biopsy or intracranial pressure monitor placed, it's recommended that they receive recombinant factor 7A. There is data to support either an IV PPI or an IV H2 receptor antagonist in acute liver failure patients to reduce their risk of GI bleeding. Nutrition is also important. Acute liver failure, like most decompensated or chronic liver disease, is a catabolic state. There is no data to support protein restricting. In fact, nutrition should consider giving high-dose protein 60 grams per day. Enteral nutrition is preferred whenever possible. Higher caloric density feeds may avoid excessive free water, which can precipitate cerebral edema. Hyperglycemia may exacerbate intracranial hypertension. So monitoring blood glucose, as many of these patients need to due to their impaired gluconeogenesis, and keeping a blood glucose less than 150 is important. These patients develop circulatory dysfunction. They should receive vasopressors, especially if their systolic blood pressure is less than 90 or their mean arterial pressure is less than 65. These guidelines are really to assist with them achieving cerebral perfusion pressures of 50 to 80 millimeters of mercury. Norepinephrine has been shown to generate consistent and predictable increase in cerebral perfusion in head trauma patients, and therefore is fairly successful in the same acute liver failure population. Relative adrenal insufficiency occurs frequently in acute liver failure, so there is data to support giving patients hydrocortisone if they have refractory hypotension. So looking at the relationship between hepatic encephalopathy and cerebral edema, in patients with early grade 1 or 2 encephalopathy, the likelihood of them having cerebral edema is fairly minimal. 25% of patients with cerebral edema will have a grade 3 encephalopathy, but the majority of patients who have cerebral edema will present with advanced encephalopathy or in a coma. Emission pneumonia also can predict risk of cerebral edema. If someone with acute liver failure is admitted and has an ammonia less than 75, they're unlikely to develop intracranial hypertension. An ammonia greater than 100 is an independent risk factor for high-grade encephalopathy, and an ammonia greater than 200 predicts intracranial hypertension. What can we do to prevent cerebral edema in patients with acute liver failure? It's most common to occur in very acute presentations like an acetaminophen overdose. Anyone who has advanced encephalopathy stage 3 or 4 should be intubated and have a head CT to look for early signs of cerebral edema. There are no randomized studies to guide indications for intracranial pressure monitor placement. Many transplant centers will do this, particularly in stage 3 or 4 encephalopathy patients who are listed for liver transplant. Unfortunately, these are risky monitor placements. There are bleeding complications in this population in 10 to 20% of patients. Other conservative measures that can help to prevent cerebral edema: quiet environments with limited stimulation, elevating the head of the bed 30 degrees, mild hypothermia, so that's achieved with CVVH, should not be treated. Corticosteroids are not useful in cytotoxic cerebral edema, which is the type of cerebral edema associated with acute liver failure. What we know is severe sustained intracranial hypertension that's refractory to medical therapy puts a patient at risk of brainstem herniation and poor neurologic recovery post-transplant. There's no data to support empiric use of treatments to reduce intracranial pressure. If you have identified cerebral edema by a head CT, involving neurosurgery is important. Giving hypertonic saline boluses every 2 to 3 hours to achieve a serum sodium of 145 to 155. Also focusing on hyperventilation induced hypocapnia, driving someone's arterial PCO2 down to 30 millimeters of mercury. When someone who does have an intracranial pressure monitor in has been found to have a pressure greater than 25 millimeters of mercury for over 10 minutes, they should receive mannitol. In mannitol refractory cerebral edema, a next step would be a barbiturate coma with either pentobarbital or thiopental. Assessing prognosis of patients with acute liver failure and whether they need a liver transplant is important. Etiology is really an important outcome determinant. If one can figure out what the etiology of someone's acute liver failure is, that can allow you to determine whether they have a poor prognosis or a good prognosis based on the etiology. There's not that many good, adequately sensitive or specific prognostic criteria. King's College criteria, of which there are separate criteria both for acetaminophen-related acute liver failure and non-acetaminophen acute liver failure, have an overall sensitivity of 61% and specificity of 86%. Patients with acute liver failure have a MELD over 32. This is a sensitivity of 77%, specificity of 72%, predicting need for liver transplant. Other things that have been looked at include factor 8 and 5, arterial phosphate levels, arterial lactate measures, arterial ammonia, AFP, serum apoptosis markers, but all lack sensitivity and specificity to really predict who is going to survive without a liver transplant. What we do know is that at 3 weeks after presentation, 90% of patients will have a definitive outcome. 45% of them overall will survive without a transplant, 25% will undergo liver transplant, and 30% will die without a liver transplant from acute liver failure. Again, one of the things that can be most helpful in predicting who should be evaluated and listed for liver transplant is what the etiology of their acute liver failure is. If a patient has hepatitis A or acetaminophen-related acute liver failure, they may well survive without a liver transplant, whereas if the patient has indeterminate acute liver failure or from another type of drug or hepatitis B, these patients should likely be moved to a liver transplant center and evaluated for a liver transplant. So why do only 25% of patients with acute liver failure receive a liver graft? The answer is related to the fact that there's organ shortages and this is a rapidly fatal disease. There is no way for us to bridge patients to liver transplant, so there's no hepatic assist devices that are FDA approved in the United States. Prognosis is difficult to assess. Some patients present very late, and this can preclude listing them for transplant. And some patients are not liver transplant candidates due to other medical problems. If you look at patients who are transplanted for acute liver failure and you compare their survival curve to those who are transplanted for other types of chronic liver disease, for the first several years, their survival is somewhat less. However, at about 3.5 to 4 years post-transplant, their survival curve is better than those of patients with chronic liver disease. And interestingly, if you look at the survival curve for patients who are transplanted for acute liver failure and divided up by etiology of acute liver failure, those patients who were transplanted for an indeterminate region or a drug-related acute liver failure have less good survival than those patients who are transplanted for hepatitis A or B. In summary, acute liver failure is defined as a coagulopathy, an INR of greater than or equal to 1.5, encephalopathy onset less than 26 weeks. Acetaminophen plus other drugs make up over 50% of the etiology of acute liver failure in the United States. Keep in mind, good prognosis acute liver failure, acetaminophen, hepatitis A, and shock. Poor prognosis etiologies of acute liver failure include other drugs, indeterminate, hepatitis B, and Wilson's disease. These patients, when they present, should be evaluated for liver transplant. Liver transplant has improved acute liver failure survival. Overall, 45% of patients survive without a liver transplant. N-acetylcysteine has a proven benefit in all etiologies of acute liver failure, more so perhaps in acetaminophen-related acute liver failure. A worse admission coma grade portends worse prognosis. And there are limited effective clinical prognostic markers in acute liver failure. Etiology, if one can figure out what the etiology of acute liver failure is often the most helpful. To move on to questions. Question 1. A 19-year-old male presents to his primary care doctor with 2 weeks of postprandial nausea and abdominal pain. His labs are noted below. Based on this presentation, your working diagnosis would not include A, alcoholic hepatitis, B, Wilson disease, C, autoimmune hepatitis, D, hepatitis B. Here, the answer is A, alcoholic hepatitis. Acute liver failure in a young man with transaminases over 1,000 who does not present in a coma has a succinct differential diagnosis, which includes autoimmune hepatitis, Wilson disease, acute viral hepatitis A, B, D, E, or Amanita mushroom poisoning. Alcoholic hepatitis alone would not cause such high transaminases. Question 2. Of the below etiologies of acute liver failure, which has the best likelihood of transplant-free survival? A, viral hepatitis B, B, drug-induced liver injury, C, unintentional acetaminophen overdose, and D, Wilson disease. Here, the best likelihood of transplant-free survival is C, unintentional acetaminophen overdose. Acute liver failure due to acetaminophen overdose, either intentional or unintentional, has a transplant-free survival of about 65%. Transplant-free survival for acute liver failure due to a drug-induced liver injury is about 30%, due to hepatitis B is about 25%, and due to Wilson disease is less than 20%.